Hey, it's Dr. Centeno, and thanks so much for joining us. Today I've got an interesting guest, Greg Johnson, who I've known for many years and have referred hundreds of patients to the IPA Physical Therapy Network. I met Greg initially because he was in Steamboat Springs, Colorado. I was in Denver, and I started seeing these patients with SI joint instability show up at the clinic. I was like, who's sending these? And then we started a relationship from there, a working relationship. And what we're going to talk about is IPA physical therapy. We're going to get into what that is, how it's different, why I refer a lot of craniocervical instability patients to IPA physical therapists. So, Greg, welcome, and thank you for joining me.
Well, it's an absolute honor to be here with you, Chris, and to be with everyone that is joining us here.
So Greg, let's start with some simple stuff. What is IPA physical therapy? Tell me about what that means.
Well, back in 1978, my soon-to-be wife and I, she was a physical therapist, and I'd met her when I was at Kaiser Vallejo. I was an instructor there, teaching an approach called PNF, proprioceptive neuromuscular facilitation. And I had opportunities from the woman who helped develop that to start teaching PNF around the country. And Vicki was a natural student, understood it, was able to use and teach the techniques. And in a short period of time, in 1978, we started teaching continuing education courses and defined our institute as the Institute of Physical Art. We probably trained over 50,000 PTs around the world. We do have in Europe and in Asia centers where we go in to teach and train in other countries our approach. I think what makes our approach unique is that it's an integrated approach, but it's one that's really based upon three major pillars. We look at the mechanical capacity of the human system, of our patients, and we have tools in which we can treat mechanical dysfunctions. They're not done passively like you would see with chiropractic and other manual therapy approaches. Ours are always done with the patient's active involvements, either through active movement or through resistance. And once we get gains in that mechanical capacity, we immediately transition into making sure that the core musculature, for those with craniocervical instability, the core of their subcranial region is one of the most important components of their training. And then we work into motor control, basically teaching them the coordinated patterns and the movements so that they become automatically in protecting those areas.
So Greg, here's an interesting specific question. We've got a lot of CCI patients who feel twisted, right? And they usually have some level of rotation at C1, C2, but they go see their upper cervical chiropractor for that. But what they may not know is about the concept of PNF and diagonals. So let's talk about PNF and diagonals and what that means to someone who feels twisted.
I'm glad you brought that question up, Chris, because I don't think that I've ever seen a person with upper cervical instability, even if it's from a major whiplash injury or whatever the underlying cause is, or just misuse, that doesn't have significant amount of dysfunction below that cranium, all the way down to the pelvis and even to the feet in many of them. And in a lot of those cases, you can find dysfunctions that put more strain on that subcranial region. And therefore, we're looking at the system as a whole. And one of the ways that we can do that is PNF allows us, through resisting patients through diagonal movements, to be able to identify the mechanical, the neuromuscular, and motor control dysfunctions that exist within their system.
So explain to the patients that are watching a movement diagonal, right?
Yes.
Concept, let's start at the shoulder and go down through the lumbar spine. What's the diagonal there? Why is it diagonal? All that good stuff.
Well, first of all, I think the man who developed it, Herman Cabot, back in the late 40s and early 50s, he and Maggie Knott, the woman that I got to work with, looked at conventional exercise, and everything we did was in straight planes. And then they went out and watched people play tennis and bowling and any other physical activity, and it's always extremities moving in diagonal to the trunk. And so it was looking at that interaction between the trunk and the extremities that was such an important part. And then he developed these amazing extremity and trunk patterns that really go within the natural DNA of our movement patterns. And so we can very quickly, through resisting an upper extremity pattern and the shoulder girdle that goes with it, and how the trunk supports that shoulder girdle, where the major problems are within that individual. So very quickly we can do a treatment or a assessment of that person to identify other areas that may be contributing to that subcranial instability.
Gotcha. So just to simplify for patients, let's say right shoulder into latissimus dorsi on that side, jacking into thoracodorsal fascia, crossing over to the opposite SI joint, and then down to that opposite hamstring. So that would be one example of a movement diagonal, right? The right shoulder locked into the opposite side of the low back.
There is so much research now into fascia and looking at those planes of fascia and recognizing the problems. And for me, early on, I recognized that it couldn't be just the muscles that was limiting these patterns, that it had to be other things. So I started early in my career studying with Rolfers and other people who were doing fascial work and recognizing how the fascia was perfectly aligned within these PNF diagonals and how dysfunction of it could be treated to enhance the performance of these patterns. So yes, whatever you do in your arm goes all the way down into your feet, and anything that you do in the arm goes up into the cervical spine.
And okay, so let's see here. Oh, one of the things I did want to touch on is tell me a little bit. I know you've told me in the past a little bit about the vagus nerve work that you do. Tell me a little bit about that. What is that? What kind of patients do you treat? How do you do it?
Well, I think it comes down to need is the mother of necessity. I had several individuals, it started out with cardiac problems, that came to me and said, is there anything you can do? And I'm always the type of person that says, let's try to see if we can't find a way to help you. And for me, it's always been a discovery of trying to see things. And I was so fascinated with the autonomic nervous system. I really believe that it had to be foundational in a lot of the problems that we were seeing, a lot of chronic pain problems, a lot of the autoimmune disorders that we were treating. And in this case, it was actually cardiac problems. And I started figuring out how to palpate and work with the nerve. And in those early times, about 10 years ago is when I started, I found that most individuals had vagus nerves that did not have normal mobility, that they were restricted, that the fascial tissue had restricted the vagus nerve through the neck and to where it goes to all the organs. It's the parasympathetic driver. And you can basically palpate when you go into neck extension, the course of that nerve all the way down to each one of the individual organs. And so in the case of the heart, mobilizing the heart to get it moving in its normal pattern, which it wasn't doing in most of them, and then mobilizing the vagus nerve to them, and then doing many of the activation techniques of breathing and other types of care that is active in the vagus nerve. So we are now really treating a lot of autoimmune disorders and a lot of digestive issues, depression, anxiety, and the one that's probably we're seeing the most patients with now is long COVID. and very successfully helping many of the long COVID patients improve and having less of the fatigue and everything. So that's been my fascination with the vagus nerve.
Yeah, no, that is super interesting. And I don't know that there's a lot of other physical therapists that are treating vagus nerve issues. Now, do you teach a specific course?
I do. I have I'm sorry, I didn't mean to interrupt you there.
Yeah.
I do have an online on-demand course that is available through the Institute of Physical Art that individuals that physical therapists and other healthcare professionals can take. And it's a 5-hour course that goes through all of the anatomy, physiology of manual therapy for the vagus nerve and ideas of how to treat it. So that is one way. And I also presented in one of the courses we have within the Institute of Physical Art is the functional mobilization for the upper trunk.
So how many IPA trained physical therapists out there do you think would know how to do vagus nerve work, or could maybe they contact you to find out, hey, I'm in Dallas, is there someone close to me that knows how to do this?
There is definitely that. We do have a online on our webpage ways to find individuals who are certified with us. So we've had around 500 individuals become certified over the years, and they can find those there. Since it's only about 10 years old and many of these people certified before then, I can't guarantee that all of them know the vagus nerve, but you could sure go on the website that you've just pulled up there, Chris, and be able to find those IPA therapists in various different locations. So I know you use this a lot. I hear from a lot of my therapists such appreciation of being referred from other Regenexx doctors, being able to see therapists around the world who have gotten actively certified.
Sounds great. So let's start answering some questions here. It's been advanced by Harry. Do you have any IPA locations in England or Europe? I just pulled it up. It looks like in the Netherlands. Is that right?
Yeah, and I think we used to have one that was in the United Kingdom, but I don't see her listed there anymore. So, but we do have individuals, and these are only the certified ones, which are probably around 500, as I said. And
Gotcha.
we probably trained over 50,000 PTs that around the world that individuals I'm sure could find.
Gotcha. Okay. And if they're interested to try to find more than is on the website, my guess is they'd probably just contact you and directly, or
yeah, they could go ahead and send an email to me, and I could be able to work with that with them if they'd like.
Okay. So let's see here. Let's get out of that. Sherry, would this be more helpful before or after a procedure? Meaning, do you do a lot of prehab with patients before procedures?
It is so foundational in our philosophy that every patient gets to be the most efficient they can in their functional capacity of the region that's going to be there, and in this case, subcranial, pelvic girdle, and being able to reduce the amount of stresses so that post-procedure, they are in the most efficient state they can be. So I definitely like to, in my patients, before I send them to you, be sure that I've got them in as efficient state as I can get them in.
Gotcha. Great. AT, how do you manage flare-ups? So I think what he's bringing up is there's a lot of, the craniocervical instability population is pretty varied, everything from functional, but I avoid X, Y, and Z, to not functional at all, and pretty much anything flares me up. I think what AT is bringing up, he's more, I know this patient, he's more functional, but how do you thread that needle with IPA? Because sometimes when you flare a patient up, the muscles shut down. So how do you get them back online? I'm sure you've got ways to do it, but maybe that's a good topic to talk about.
Well, I do think, and through the tools that were developed in PNF. We've advanced on those, particularly my wife, Vicki, who has really developed tools, first of all, to get the core to fire. And most of that is through use of prolonged holds, being able to resist somebody to develop that, because every cervical instability patient I've seen, particularly subcranial, have inhibition of their subcranial muscles. They need to be activated early on, and that's really what helps to reduce the possibility of flare-ups. When somebody's in an acute flare, then we apply manual therapy to the muscles that are usually in spasm, and gently try to mobilize those joints back into a less dysfunctional position. That subcranial region, when they're hypermobile, just even through a night's sleep, quickly can lose its normal mobility and become symptomatic. And so we work hard with that. We train them on many procedures they can do on themselves to be able to mobilize those dysfunctional soft tissues and joints. And so flare-ups are definitely a challenge, and we have to always have time within our clinic to work somebody in who's in the middle of a flare so that we can assist them.
Gotcha. Okay. Do IPA PTs work with clients? So I'm sure you see a lot of patients with scoliosis. Scoliosis could be the original diagonal disease, right?
It is.
Meaning that, and again, just so you guys understand, we're talking about these PNF diagonals, meaning, from, let's say, your right shoulder down to your left low back. Well, if that's not working, the first thing that's going to happen is you're going to start to twist and bend. So talk about scoliosis and IPA and PNF.
Well, anytime that the spine starts to be able to go into a curve, and as far as therapists go, I don't think there's such a thing as an idiopathic scoliosis. Every scoliosis has a reason behind it. It's just we're not smart enough to figure it out in some cases. Because they can have a genesis that begins in the pelvic girdle, but really ends up being dramatic in the cervical spine. Or they can have a genesis that starts in the thoracic spine as a trauma in youth that slowly develops into a curve. We work really hard within the fascial system, within the articular system, and then within the use of PNF and those diagonals to retrain the muscles to be able to help that curve not to progress, and in many cases be able to reduce it. But a curve below, a cranial instability above, is a real problem for that average individual, because every time they twist and turn their trunk, they have those restrictions within it that immediately strains the neck. And so often in a scoliosis, the head and neck at C1 on 2, degree of rotation to it as they appear to be trying to look forward.
Gotcha. And there was just a pretty good study that talked about a specific genetic defect that was linked to scoliosis, but only when there was a kyphosis that developed. So the kyphosis,
that's correct,
with the genetics allowed basically the left-right plane to destabilize into rotation and side bending. So that was kind of interesting.
Yeah, completely agree. And I do think, though, that there is definite predisposition in certain bodies. But you can look at families and believe that a whole group of them probably have the predisposition for scoliosis, but only a certain number of those will start developing a noticeable or a concerning scoliosis.
Now, I can't imagine that there aren't any IPA PTs in Canada.
We do have some trained in Canada, and there's no doubt that it's not as many as we would like. And we have got a goal to start trying to do more of our trainings in Canada, and we've got some invitations to be doing that.
Yeah, I tell you, Canadian PTs, you better get on it here, because you got a good one here, and you gotta grab it while you can. Hey, just from a housekeeping standpoint, if you're watching this, please like, subscribe, and share, because at the end of the day, if you want to pay it forward to others in the CCI or spinal injury community, the way to do that is to make this easier to find for those patients. And the way to do that right now is to hit that like button, share, subscribe, whichever channel you're on, because that makes it easier for people to find who are injured. So thank you for doing that here. AT, can you provide some insight on how specifically IPA providers treat patients with vagus nerve issues? I think we talked about that, right? It's mostly mobilizing the fascial plane that the vagus nerve is running in. Is that correct?
Yep. There is some real research that really come through that shows that any tension placed upon the sensitive structure of the parasympathetic, sympathetic nerves can impact the ability for the flow of nerve fibers, and therefore they don't function as efficiently. And I can tell you, we've just had individuals, once that nerve starts moving, just starts rehabbing much quicker. They're sleeping better. They're having a lot less of the problems that occur when that parasympathetic system isn't active.
And for patients, think about a nerve as a Chinese finger trap, right? You know those Chinese finger traps, you push them in like this, they get bigger, you pull them out like that, they get thinner. That's actually how nerves are constructed. Nerves are meant to move with us, and when they can't move with us, they get scarred down. That can lead to all sorts of havoc, and for that particular nerve, vagus nerve, it's connected to so many different systems that the last thing you want, obviously, is havoc in that nerve. Question, I don't know if you know this, do the Netherlands people have any training in vagus?
You know, I'd have to research that to see if they have taken the vagus nerve class. We definitely have had a lot of PTs take that class, and therefore they would be. So I'd have to research that. I'm not aware of exactly who in the Netherlands right now are the therapists that we have there, but I do believe one of them has taken it.
Gotcha. Let's see. Persons with vestibular disorders with retraining posture, functional control, and relearning how to walk with poles. Yeah. So Natasha, I think that's what Greg is talking about here is that twisting that I get asked about a lot by patients. You know, that can be proprioceptive from the top. It can also be coming from the bottom up. And how you rehab that twisting is by rehabbing that diagonal, which is really the foundational support of IPA physical therapy. Let's see. I'm just trying to go to the ones. I don't know if Chris, I can vouch for all of this. Great, Chris. AT, Greg, what's your opinion on the next level device? You may not have seen. Have you seen that little next level thing? What are your thoughts on next level and using it for at-home neck strengthening? Have you used it in your clinic? Just give me your thoughts on it.
I have not used it in the clinic. I do have a couple of patients that swear by it. And I had one patient who returned hers because she got aggravated with it. So I do not know enough about it to place guidance. But talking about devices, there are many vagus nerve activation devices now on the market. Truvaga is the one that I like the best, that patients can actively stimulate their vagus nerve at home. And I've had several patients now getting very good results. These devices run $400 to $600, so they aren't exactly cheap. But for patients with autoimmune disorders, they definitely have been very helpful.
Yeah, so this is a little Truvaga device. We've
You
also
are quick at this.
yeah. I've had some practice here. I do this every week now. Some of these patients are getting tired of me here.
They can't be. They don't know how lucky they are to have you in their life, Chris.
Well, thank you.
What you have accomplished, and just so that everybody can kind of have an understanding, our challenge, our blessing is a medical profession that does have tools that can really help us to get out of pain and to get in other areas. But there are so many of us that don't have solutions through the regular medical profession. And Dr. Centeno has expanded our ability to work together to non-invasive, non-pharmacological treatments to really be able to help our patients. And there's nothing more important for those of you that are physical therapists out there than find a Regenexx physician to be able to work with.
Well, thank you, Greg. And vice versa. Again, like I said, I think we chanced upon each other because we were close, and it's been a great working relationship through the years, for sure. As far as Canadian physical therapists, I would think that the average Canadian or average American physio, that's one of the things to understand here. When we talk about IPA certification, we're really talking about a different level of knowledge than the average hospital or clinic physical therapy that comes out of school, learns a little bit of this, learns a little bit of that. But really, there's a big difference here in what we're talking about. So whether it's Canadian or US, I think it's the same thing. You're not going to be able to Google a physical therapy provider in Canada or the US and find someone that has this kind of training. You got to go on that.
I would like to at least say that Canada is one of the most advanced countries as far as physical therapy is concerned. The Canadian Association up there, there is an organization here in the United States called NIOMP, which teaches the Canadian approach, and they are very advanced, as well as those in Australia. Probably Australia and Canada have some of the most advanced physical therapy practices as a general rule around, because they do teach manual therapy, which regretfully here in the United States isn't being taught in PT schools to the degree that it should be for its value.
Well, let's talk a little bit about that. So if you're in Canada or Australia, how do you find someone with that training? How do you spell that, NIOMP?
NIOMP, N-A...
N-A-I?
I-O... and it ends with PT. I don't know how to spell it.
I think I got it right here. Yeah, I got it. So would you try to, if you were in Canada, and
I would go to NIOMP to look at
NIOMP providers, and that's this right here.
That's it.
And so that's great. So if you're in Canada, this would be the folks you want. Now, does this also apply for Australia, or is that different?
No, in Australia, it's the Maitland approach. So
Maitland
approach is in Australia.
Well, we're getting all sorts of great information here.
And those are definitely therapists that are trained in manual therapy, that understand the function of the body. I don't believe any of them are treating vagus nerves now. Not many of them do PNF resistance and really utilize those components. But they are far and above the average physical therapist who basically does exercise and some modalities.
So it looks like this is your website for the International Maitland Teachers Association, where you can find a therapist as well. So again, if you're ex-US, these are all great resources in which to try to find someone who, again, is taking it that next level, because you're not going to find this level of expertise in the average physical therapist who isn't spending additional time, energy, and effort to learn once they get out of school. But if you can find one of these providers, you're really dealing with a completely different animal than the average PT at the local hospital.
Very true.
Okay, so another question. This is an interesting one, and one I think that is that we talk about a little bit, and that is there's this tight phylum concept with scoliosis. Do you find that you need to do something with the phylum terminale with some of these patients, or is it much more related to the failure of the diagonal?
Well, no, there really is that limitation of the phylum terminalis that occurs. One of our foundational places we go to treat very early on in scoliosis is the tailbone, the coccyx.
Mhm.
Its dysfunction really affects that whole spiral diagonal up the dura. And a lot of times by mobilizing the coccyx at one end and the sphenoid at the opposite, we can take away a lot of that very deep down core spiral diagonal dysfunction that affects them. So yes, I do believe that it is a cause of problems. Right now, I think it is a cause of scoliosis. It can be a precipitator of scoliosis. I don't know that it's a cause.
Gotcha. Okay. Sherry, how long is the average course of treatment if you've got a craniocervical instability patient? Let's start obviously with someone who seems to have craniocervical instability. They've got upper cervical symptoms, headaches, imbalance due to the upper cervical spine, but they're still functional. They just live in a little box in which they've created their functional box. How long do you spend with that person? Is it weeks? Is it months? What's that course of care usually look like?
Well, this is a great question, Chris. First of all, we've got to test them to make sure they don't have red flags,
Gotcha.
that they don't have such alar instability that it's creating symptoms going all the way down to the feet, that it's not causing nausea, dizziness, that we're not affecting the vertebral artery or the other surrounding structures. If there's red flags, our responsibility to be immediately is to have them checked out neurologically. And so if they do not have red flags, which a majority don't, then we begin working on them with the knowledge that most of them are going to need to come to see you, in our case, to get further workup to get those ligaments more stable. Can we reduce that instability up there? An interesting factor is most C1, C2s do not have universal instability, meaning multi-directional. Most of them have certain directions in which they are very hypomobile. So a lot of our assessment is to find those hypomobilities so that they have greater options for movement, which allows that upper subcranial region now to not be under so much strain, because a lot of them are having habitual patterns of movement that causes that instability, that causes those limitations, emotions up there, the muscle spasms, and those severe headaches.
So that's an interesting thing. Let's dive into that just for a second. And I think it's something that most patients, physicians, physical therapists even don't understand. And that is that hypomobility, lack of motion, and hypermobility can live together in the same patient, interact, and play together. So talk about that. How does that work?
Well, it is very fascinating. What you can do is assess with your hands that C1, C2, and let's just stay right there right now, as to their movement patterns that are accessible to them. Once somebody has a trauma that creates an instability, it's usually unidirectional, finding out which way that instability is. They usually have multiple other directions that need to be mobilized, both the fascial tissue, the soft tissues, to get them back into a normal plane of movement so that they now have three-dimensional movement that system is designed to have. And then we retrain the muscles for their core firing and for their PNF diagonal abilities.
So they might be hypermobile in certain directions at C1, C2, and hypomobile.
Absolutely.
In other directions at C1, C2, and the hypomobility can drive the hypermobility because those are the only things that are available to them in movement. So they're actually, without knowing it, moving into areas of hypermobility because they don't have the hypomobile range to move into.
That's correct. Gotcha. Very well said.
And let's see here, Greg. Oh, so this is an interesting one. Do you guys use deep neck flexor training?
We do.
Train suboccipital muscles.
Yep.
You know, how does that work?
Well, it is again the core muscles that have become inhibited. Core muscles tend to be what Bear Mog the local muscles compared with the prime movers, which are global muscles. So they could be looked at for their muscle fiber, the tonic and phasic, primarily tonic. And they become inhibited from trauma, from repetitive pain in the area. And a lot of times, according to the work of Hodges out of Australia, they don't automatically turn back on again when the problem's reduced. So it takes active, deep cervical training, both as a home program and also by the physical therapist doing resisted to the area, to reinstate these normal movement patterns and this normal core first strategy is what Vicky has termed it.
So Paul Hodges, Julie Hyde, and now Jim Elliott has also been doing some great
lots of work.
Yep. Started this concept that we have these deep muscles and that sometimes they get atrophied and don't recover. And when they don't recover is when all hell breaks loose in that functional spinal unit in the spine. And I've shown lots of patients that atrophy, it's super easy to find on MRI, although it's rarely commented on. But when Greg is talking about this, that's what he's talking about, trying to get those deep segmental muscles to fire again, whether they're suboccipital, mid-cervical, low back, whatever, it is a critical component in getting the person better. Let's see here. Okay, sounds like they're getting now more into questions for me. So Greg, if you could, just give me a quick wrap up on the idea of IPA physical therapy and the top 3 things that make it different from the average physical therapist that you can find down the street. So what are the top 3 things that make IPA different? I know I'm putting you on the spot here, but I guess is you probably answered a similar question.
Number 1 is really the evaluation that believes that a problem is never a local problem. That local problems, even though if they were from trauma, usually are further aggravated by other parts of the system. So our whole approach is looking at a full body approach for being able to treat, whether it's cervical spine, we look all the way down to the foot and ankle in those individuals. So 1 is a total body approach. 2 is the way we apply our manual therapy is that we do it dynamically. We have somebody doing resistance. It's a team approach that the patient should experience, that they're as much involved in their recovery as the therapist who's working with them. And so we work within that to enhance their mechanical capacity. And as I said, we follow through with training to develop their motor control. So at all time, the motor system has to be essential. And number 3 is we believe that we have to train each individual in depth through what we call a body mechanics training product, which Vicky has really developed in her Core First Strategies courses, to be able to train a person to use their body more efficiently so that it's automatic, not just cognitive training, but training so that it's an automatic training to have more efficient posture and movements. And this is how they get a hold of us, is through our webpage of the Institute of Physical Art.
Yeah, and again, guys, I want to thank Greg for being with us today, because it's critical to understand, and Greg has given us some fantastic information for our ex-US patients as well, that finding a physical therapist with a much higher level of training is critical if you're going to be successful in rehabbing, whether it's from craniocervical instability, chronic low back pain, cervical radiculopathy, whatever it is. So I want to thank Greg for joining us.
You're welcome.
I'm going to get into answering some questions here, Greg. So I will say goodbye and thanks so much for today.
Thank you very much for inviting me, Chris. It was just an honor.
Thanks. Okay, guys, so we are going to try to answer some questions here. Can you comment on comprehensive regenerative injections that target not just the joint spaces, but also extra-articular? Yeah, guys, I think what this brings up is an important issue, but I think it's also a little bit of a red herring as well, meaning that there are lots of things that provide stability. We just talked about the physical therapy side, the muscular side, the fascial side. There's also obviously ligaments. Now we want to target the prime ligaments that create stability. And then there's this concept of what's called extra-articular. Now realize that it's a little bit different here, right? Most providers who talk about injecting the joint capsules, it's kind of doctor code for, I never really learned how to inject the joint itself. I don't have that level of training. I don't have that level of equipment. So I'm going to try to pretend that if I just inject the joint capsule, that's really the best thing to do. It's really not. So again, the focus should be on injecting the joint itself. That takes more training in the spine, as we've talked about. And also, if you need to inject the joint capsule, that's great. And then obviously there's lots of other ligaments out there outside the joint or extra-articular that should be injected. So I think it's important to realize, though, that many times that discussion gets co-opted by this idea of physicians who don't have the training in how to inject those joints, focusing on the concept that they're injecting, quote, the joint capsule, which is really just doctor code for, I don't have the training to inject the joint. Let's see, I think we got to that one already. I'm trying to catch up here. Walter, I noticed regenerative treatments to the neck plateau until relatively asymptomatic pelvis dysfunction gets addressed. Can you explain why this is? How can you screen for these patients? Not quite sure I understand the question, but I think the question is, if you've got SI joint instability, for example, should it be treated if it's not symptomatic? And the answer would be, for the most part, no. But if it does seem to be causing issues with the kinetic chain all the way up, i.e. the patient says, you know what, I don't have a lot of back pain, but I do feel my right SI joint kind of slips out of place and then I get a headache, then absolutely it should be treated. Let's see here. Trying to get back to the regular Regenix or CCI questions. Dr. C, I found your testosterone therapy video very interesting. It's almost as if people concerning TRT might want to wait until after stem cell procedure start for a higher capture. Yeah, I think what's happening there is that there's two different issues here. One issue is, can hormone replacement therapy as you get older help? I think so. I think there's pretty good literature on it. I've certainly seen enough patients on hormone replacement therapy. It seems to help with things like metabolic syndrome, which we know can drive joint destruction and inflammation. So I think it's generally a good thing. Now, there's another concept out there that the average person needs to get their hormones optimized before getting, let's say, a bone marrow construct stem cell procedure. We tested that one. We did some extensive testing on that. That was about a year long, cost me probably $100,000 to do that research project. And we took a bunch of patients. We optimized their hormones. We took a bone marrow aspiration. We took a bunch of patients. We didn't optimize their hormones. We took a bone marrow aspiration, and then we mixed them all up and looked to try to see, did their stem cells get better as a result of optimizing hormones? And the answer is they did not. So if you're hearing this concept from someone that does hormone therapy, trying to push hormone therapy on you, which hormone replacement therapy would be things like replacing your testosterone if you're a man, or optimizing your estrogen, progesterone, and a lot lower level of testosterone if you're female, and that needs to be done to optimize your stem cells. That's been studied. We studied it. It didn't work. Now, we were hoping it would work, right? I didn't do the study because I thought it wasn't going to work. I thought it was going to work great. It didn't work. So it's important to understand that. Let's see here. Do you often see Chiari mistaken for CCI the other way around? Can CCI cause Chiari? This is an important one. I'll get rid of it's probably driving you crazy as this thing goes through here. Chiari malformation. Chiari malformation is a lot like cervical medullary syndrome. They live in the same world. I just did some videos on this morning that'll be coming out here in the next week or so. They're both fixed anatomical things, including a retroflex dens, that normally don't cause any symptoms. There's a lot of people walking around with a retroflex dens. There's a lot of people walking around with a dens that abuts against their medulla, or quote cervical medullary syndrome, but have no symptoms. There's a lot of people walking around with a Chiari 0 CTE or Chiari 1 who have no symptoms. So how do they get symptoms? They usually get symptoms because there's a breakdown in the musculoskeletal stability. So we just talked a lot about fascial and muscle stability. The same thing can happen on the ligament side. The stability system goes south, and all of a sudden those fixed things that weren't causing symptoms before start causing symptoms, and they actually act as accelerators for those symptoms. So it just means that all things being equal, they're like adding gasoline to a bonfire, but you got to light the fire. Their whole life, the fire wasn't lit because they weren't unstable. But as soon as they became unstable, that fire got lit, and those things made them more likely to get symptoms. So the approach is not to rip out your dens if your dens is close to your spinal cord or medulla, or to fuse your upper neck and decompress back here if you've got Chiari, because there's lots of people without any problems who have Chiari. There's lots of people walking around out there who have retroflex dens without any problems. The goal is to treat the instability. Now, there are some patients that may need those more drastic measures because they didn't get diagnosed soon enough and things are bad enough. But the goal would be not to start there. And that's because fixed anatomical problems only act as an accelerant for instability issues and symptoms. They are not generally the cause of those symptoms. And that's something that's really important to understand. Bo, my daughter has had her DMX imaging, is almost 9, and her age can be considered for posterior injections. But we normally don't take people or young people who are not skeletally mature. So they have to be skeletally mature. And that's because of our concern that we don't really understand or know what happens in a patient who's not skeletally mature. Now, I would say, for example, if we're talking about just simple posterior injections, things like prolotherapy, PRP, that more likely than not, that's not a problem. But if we talk about more advanced things where we're going to be treating the patient with bone marrow concentrated bone marrow stem cells, then that could be a concern. James asked, where is Greg located? Greg is in Steamboat Springs, big ski area here in Colorado, a little bit off the beaten path from the main I-70 ski areas, but a fantastic ski place, one of the best ski places on earth, actually. Let's see here. Christine, do we have a list of symptoms that we see with CCI and vagus nerve? Yeah, vagus nerve symptoms tend to be more the autonomic symptoms, so things like POTS, things like tachycardia when you move your head around, or unexplained tachycardia, GI issues. Those are all vagus-mediated or can be vagus-mediated problems. Now, there's lots of other causes for those things as well. So those need to be ruled out. Bo, is higher dissection of the nerves done through posterior injections? Yes, when we're doing posterior injections, we do a lot of higher dissection of the lesser occipital nerve, great occipital nerve, third occipital nerve, superficial cervical plexus. All of those are commonly done if that particular patient has an issue with that particular nerve. And that's the important part. To remember, all of this treatment is highly customized for the patient. So it's critical to remember that that nerve has to be involved. Before I take another question, I'm going to just go ahead real quick and put a plug in for a few things. Again, like, comment, share, subscribe, just some housekeeping, just because at the end of the day, that's how other people find this content. If you've got a question to ask me directly that you want an answer in writing on, I have this PICL Reddit, which is slowly but surely growing. And the goal here is to create a very, very large amount of questions and answers that anyone can go and search online, that questions that have been answered by me personally. If you're interested as a patient to get more patient-to-patient interaction, which is incredibly important. Sometimes you don't want to hear from the doctor. Sometimes you want to hear from other patients that have been through this, and I get that. Then that's this group, craniocervical instability PICL procedure. It's run on Facebook by some very knowledgeable patients that don't put up with crazy stuff. And I like it because of that, because oftentimes I see many of these social media threads just go off in tangents that don't make a lot of sense. So these guys don't really allow that kind of stuff. So again, this PICL Reddit is where you can get questions answered by me. If you want to talk to other patients, then this is a great place to go on Facebook. So let's get back now to answering some more questions here. I wish I could pronounce your first name. I am not. Andra, maybe. Dr. Centeno, is it necessary to do an upper cervical MRI to figure out which ligaments are injured, atrophied, or the supine MRI combined with CBCT is sufficient? Yeah, so you're going to need it. So diagnosing instability. Instability is a movement-based concept. So you have to have movement-based imaging. So a CBCT is not usually movement-based, although if it was, that would be good. A supine MRI is not at all movement-based. So while I can see hints on your CBCT or hints on your regular supine MRI that might indicate circumstantial evidence of instability, we need movement-based imaging in order to determine if you have instability. So that's going to be an upright MRI with flexion and extension, for example, or a digital motion X-ray. Or if you're from Europe, we've got 2 videos are out there right now to try to use either a regular X-ray or DDR or CDMA. Those are all different X-ray technologies to replicate what we're looking for on a DMX. And those are videos that you can share directly with the specific place that you're going to get imaged. They can watch the video and hopefully get you imaged, and maybe that'll help. So I have put those together. Mr. Nick, thanks, Mr. Nick. Do some CCI patients present with uneven pupil, one pupil more dilated than the other? Yeah, so I have a video on that, that if you go to my YouTube channel, my YouTube channel is kind of exploding right now because I have been very, very active lately. I'm on a roll here with the YouTube videos. So that is right here. And if you were to type in here on my YouTube channel, and this is my personal channel, you can see all the stuff I've released more recently here. But if we are to dial that in here, I don't know if it'll come up with pupil, but I'll give it a shot. Yep, right here. This is the one I was looking for here. So, can your net cause blurry vision? That's a Facebook Live I did a while back, maybe a year ago or so. But that would be the one that you would want to find on that topic. It talks about how CCI can irritate the sympathetic nerves, which can lead to one pupil being different from the other, which leads to blurry vision and all sorts of other problems. So I'll leave that up for a second, but that's where you would go to find that. AT, I've got 0-2 instability, significant hypermobility, lower cervical spine. Yeah, so that's exactly what Greg was talking about, and that is that idea that hypomobility can drive hypermobility. So I think it would be a great idea to find some of those therapists and try to get the hypomobility worked on. Let's see here. I'm trying to see if I can get some newer questions here. You recommend dry needling after PICL, but it relaxes your muscles and not retain muscles. A lot of CCI patients fail after dry needling. Why? Yeah, I don't necessarily recommend dry needling after PICL. I'm not quite sure where that one came from. Listen, dry needling can be a very helpful thing. What that means is it's getting rid of trigger points within muscles. Muscles can have areas within them that are hypokinetic, that don't move. Those are called trigger points. And you can get rid of them by just dry needling it with an acupuncture needle. Now, many CCI patients need muscular tension and spasm and tightness to maintain stability. So many times, if you get rid of these trigger points through dry needling, it'll flare them up because they need that tightness. Having said that, in the process of getting stronger, you're going to want to get those muscles back online. If you can't get them back online through things like IPA physical therapy or postural work, then you may need dry needling to assist getting those muscles back online. So it's a little bit of it being a bit more complex than it seems. Jay, hi, Dr. Centeno. This is James. I've had a bit of troubles getting my pre-screen packet to you. I've resent it to your office just Friday. Yeah, James, or I'm sorry, Jay. I apologize, Jay. I'll put my email address down here and just send it to my desk, and I'll kind of try to move it forward from there. I'm just putting the email address that goes to my desk here so that you can try to move it forward that way. It'll be in the comments there. Okay, here I'm trying to get to some small questions here right before we end this up because we're getting close. Well, thank you, Natasha. Yes, it does take some dedication to do all this, answer all these emails, answer all these online questions, do these things, create videos to try to educate patients. But again, my background goes to the idea that when I first became a doctor many, many years ago, one of the problems I had was that in my experience, doctors were not very good at explaining things and talking to patients. And I would find that many of my colleagues would go into medical speak mode when they talked to patients. And while I could understand what they were saying because I was being trained in medical speak, I was shaking my head and saying, this patient isn't understanding a word you're saying, doctor. So I've always tried to make it my mission to educate patients, because an educated patient does better than a patient that just doesn't have any idea of which end is up. And so thank you for bringing that up, and thank you for recognizing that. Listen, guys, this was a different Facebook Live. I did want you to meet Greg. I did want you to get introduced to IPA physical therapy, because at the end of the day, it's a different approach to physical therapy. I've been using it for years. I've referred hundreds of patients to them. We've referred hundreds of patients to Todd Ball. That's more of a postural approach. This is more of a PNF muscle activation approach combined with advanced mobilization. Todd Ball can be a great place to start And then IPA can be a great place to graduate to once things start calming down. And that's how I've dealt with both of those in the rehab program that I have online. I want you to watch those videos as well. So thanks so much for watching today, guys. Again, I know it was a little different, but I wanted you to meet Greg. I wanted us to banter back and forth a little bit and then me get to some of your questions. I'll be back next week with another topic, dropping lots of videos on the YouTube channel. Pretty much one a day here is probably going to be the pace. So pay attention there. If you're interested in getting questions answered by me, go to that Reddit thread, which is RPICL. If you're interested in learning more from other patients, go to the Facebook group that I talked about. Thanks so much for watching, guys, today, and have a great week. And I'm glad that you guys got to just some banter back and forth about what IPA is and why it's different. Thanks so much. Have a great week, guys. Thanks.